Good afternoon. I'd like to talk a little bit this afternoon about information about recently introduced antiretroviral therapy and some of the newer drugs that are becoming available. Now, these are my disclosures. So what I'll talk about this afternoon are 4 potential new treatment options, and I've ordered those in terms of how close they are to becoming widely clinically available. So running through those, cabotegravir is licensed in many countries, some for just treatment, some for treatment and prevention. Lenacapavir has got limited licensing in some countries for heavily treatment experienced patients. And islatravir is undergoing clinical trials, although they were stalled for a while, and broadly neutralizing antibodies are probably the furthest away and on the horizon. So I'll try and cover those ones for us today. So cabotegravir, just briefly, as prevention, you may be aware that there's 2 quite compelling pieces of evidence have come out this year, the HBTN-043 and 084 studies, which looked pretty much at the same style of study, which was cabotegravir versus the standard TDF-FTC for prevention, but in 2 groups of people. So MSM in one study and cisgendered women in another. And in the MSM population, which has already been published and widely discussed, cabotegravir was shown to be superior to the oral daily dosing of TDF-3TC. More recent data in the cisgendered woman showed an even greater impact of cabotegravir long-acting as a preventative strategy there. So that sort of is very compelling information that is probably going to change the scene of preventative therapy for HIV. Now, just a little bit on side effect profiles with the injectable therapy. As in many of the treatment studies, the preventive studies also showed that most of the adverse events were injection site reactions occurring early in the piece and then dropping off to about 1 in 5 participants later on. Now, cabotegravir as treatment. Previous studies that you may be aware of have looked at cabotegravir up against what we might call older antiretroviral regimens, but in the SOLAR study, it was presented comparing it up against what you might consider one of the best single tablet regimens, which is Biktarvy. So 2-to-1 randomization in people who are already suppressed and tolerating their Biktarvy, and looking at the ability to maintain viral suppression. And it was quite heartening to see that in the study overall, the 2 regimens were very good. Viral failure rates were 1% on the injectable therapy against the expected none that you see with Biktarvy. So that study met the non-inferiority criteria. I would point out that there were a small number of patients who did fail despite apparently complying with the treatment regimens. And as we've seen in other studies, with failure comes the possibility of both integrase and non-nucleoside resistance. So tolerability-wise, again, it was almost entirely injection site reactions were accounting for adverse events on that. However, what was quite striking was that the patients who were taking injectable therapy really did want to do that in terms of a way of sort of hiding or not thinking about their HIV medication from others. Now, jumping on to something completely different, so islatravir is a fairly novel class, a reverse transcriptase translocation inhibitor that's been under clinical trial activity for some time now. So most recently at the IAS meeting in Brisbane, there were a number of studies that looked at some interesting aspects of this. So one of those compared islatravir with doravirine to BF-TAF as initial therapy. And that study design was people over 18 years of age with detectable virus, no evidence of resistance, and no active hepatitis B. And the study design looked at following those people with either doravirine, islatravir, or Biktarvy over, the plan is for 168 weeks. Now, that was stopped short because of toxicity concerns, but I'll just highlight that the study was actually recruiting subjects from most parts of the world except Africa. And pleasingly, what we're seeing is that the islatravir doravirine met the non-inferiority criteria up against Biktarvy. And in fact, when you look at possible virological failures, they were actually slightly less, although there wasn't a significant difference. So what we're actually seeing is most of the previous studies of second-generation integrase inhibitors had been showing superiority with other classes of agents, but in this particular study, that wasn't seen. However, again, there is that potential concern about possible resistance in the small number of people that do fail. So, for example, one patient on the islatravir study who did not fully suppress ended up with resistance to the non-nucleosides and the NRTI or the doravirine component as well. Whereas, as we've seen with various other studies of Biktarvy, people who fail don't have resistance. So this is confirming sort of the same response seen in quite a few other people. Now, what was seen in the study, and I will point out that it was a 0.75 milligram dose of islatravir that was used throughout, was what looks like to be a small but significant difference in CD4 recovery. And it looks like it's more a blunting of the higher levels of CD4 recovery that was seen. So that did cause the study to be halted and has now led to a reevaluation of the dosing of islatravir. Now, one of the interesting things that I found in the study was that there's now been a concern about the only real toxicity we're seeing with antiretroviral therapy appears to be weight gain, which has often been associated with the second generation integrases and TAF therapy. But in this study, you saw identical weight gain when there was no integrase and no TAF in the doravirine islatravir arm. So conclusions of that study was that the doravirine islatravir was non-inferior and generally well tolerated, apart from small but significant differences in CD4 recovery. So that has now led to the abandonment of that 0.75 milligram dosing schedule, but a reassessment is about to start looking at a lower dose. So we'll wait to see what happens on that one. Another interesting study looking at the islatravir, again combined with doravirine, was in a switch, or in fact two switch studies. So 017, 018. So the 018 study was people who were stable on Biktarvy, whereas the 017 was people who were stable on a range of other regimens, and again randomized to either staying on their existing regimen or switching to doravirine and islatravir. And just to highlight some of the breakdown on the people who'd switching off older therapies, most of it was integrase based, and most of the integrases were dolutegravir based. If it was non-nucleoside, it was mainly efavirenz, And if it was protease inhibitors people were coming from, then predominantly darunavir. Now, interestingly enough, in this, what you saw is overall there was no change in weight with switching, but a weight gain in people who came off either efavirenz or TDF. So that's sort of challenging our current urban myth that it's the TAF or integrase inhibitors that cause weight gain, where it seems to be the study is pointing to more that it's the efavirenz and TDF are weight suppressant. And once they're removed, you'll see weight gain. Okay, so let's jump on to lenacapavir, which is quite an exciting new class of drugs. So unlike many of our previous therapies, this is a capsid inhibitor. So we haven't really looked at how important capsid is in the whole viral life cycle, but it has a number of parts through to initial entry of proviral DNA into the nucleus, and then as new virus is being made, it has to reassemble and bud off as infectious virus. So lenacapavir actually blocks multiple sites in the capsid pathway. Now, many of you will be aware that a lot of excitement was generated by the Capella study, which was looking at people who were highly treatment experienced, who had limited treatment options, where lenacapavir was given to those individuals with quite dramatic drops in viral load. So I don't want to repeat all that study, but just to highlight that while that potency is there, perhaps the genetic barrier that we see with, say, the integrase inhibitors or protease inhibitors may not be there. And I say that because just focusing on a small number of people who failed therapy, they did so with a number of mutations in the capsid gene. So more importantly, when you look at the fold change, so this is how much lenacapavir is needed to overcome those resistance. And what you find is the commonest mutation at position 66, you now need 138 times as much lenacapavir to be able to suppress that mutant form. So those are showing that when resistance happens, it's high-level resistance. How quickly does that happen, which gives an idea or an indication to us as to how potent or robust the regimen is I picked out a few individual case reports of people who have failing to try and highlight this. So this actually shows individual patients' viral loads and the timing of their lenacapavir injection, and then actually showing how soon do you actually get rebound in virus with resistance. So what you can actually see is, initial drop and then quite quick rebound within about 6 to 8 weeks following initial therapy. And again, in another patient who really didn't have anything that was working in their background regimen, so only relying on the lenacapavir, you saw initial drop and then really quite quick rebound in viremia, again with resistance. So that's the sort of pattern or the speed that we used to see with some of the non-nucleoside agents that were also potent but vulnerable to resistance. So my take on that means that this is a new class. It's, because of its pharmacokinetics, certainly suitable for weekly oral dosing or 6-monthly injectable dosing, very potent but vulnerable to resistance if it's not paired with enough fully suppressive other agents. Right, finally then, what's sort of furthest on the horizon are the broadly neutralizing antibodies. So what we're talking about here is what I'd say is a high-risk strategy for HIV treatment, because when you look at HIV and where to target antibodies, you've really only got the envelope proteins to use as targets. And I say it's high risk because they are extremely diverse, and you get most of the variability of HIV within the envelope. And also because of the high level of glycogen coating, a lot of this is hidden from antibody sites. So it's quite tricky to design antibodies that will find the particular protein and be broadly neutralizing enough to attach and eliminate that virus. So just sort of highlighting where things are at, there's actually quite a few candidates that are under study at the moment for possible consideration or clinical trials. And they are targeting things like the B3 glycogen site, again, a high-risk strategy because this is one of the most hypervariable regions of HIV, the V2 apex, the CD4 binding site, where a number of candidates are probably most clinically developed, the GP120, GP41 interface. So this is where once binding with CD4 happens, you expose that GP41 and potentially antibodies could lock into there. And the GP41 HPMR site, which again is important for the second phase of or allowing membrane fusion between HIV and the target CD4 cells. So how far advanced are we with these? So what we've got here shown in green are the number of clinical trials that are ongoing, looking at a range of candidate neutralizing antibodies, some orange ones in preclinical development, and the ones in reds are where their development has halted at the moment. So that at the next stage of development of these candidates is really looking at not just a single agent, but more likely multiple agents. Now, what I mean by that is this particular small study was looking at a combination of three broadly neutralizing antibodies in a small number. So this is only 4 patients and their responses. And what you actually are seeing already is sort of a drop in viremia that's quite pronounced, but you're actually seeing fairly quickly afterwards rebound starting to happen in some of those individuals. So quite a mixed response, even in a tiny number of clinical trial participants. So where are we at with that? There's a number of other combination investigational antibodies now being designed to target multiple sites. So one of the studies that's recently presented about this is with lenacapavir with 2 of these candidates. So I'm not going to try and sort of pronounce or mispronounce the names of those, but they've been abbreviated to TAB and ZAB, fortunately, in this clinical trial. And looking at the dosing schedule, lead-in dose, lenacapavir injections, and then antibody infusions. Now, only a small number of people have been studied with the 2 doses there, but you saw 90% or 9 out of 10 of those individuals actually were able to suppress their virus out to 6 months. However, 1 patient did fail on that. So where are we at with that huge number of potential drugs used as broadly neutralizing antibodies? It looks like many of them are not broad enough to cover all the potential envelope variants that are around. Partly that's because most of them are based on ChB virus, which is not necessarily the commonest variation of HIV you find around the globe. And most of the time, some screening tests are required to see if an individual's virus actually match up to the antibodies that are being tested. So that requires a screening assay, and at the moment the screening assay is estimated to only be about 60% sensitive, so has the potential to miss what you might call resistant variants of HIV. So whether this will actually progress into a clinically viable treatment option or not, I think is probably a little bit too early to say, but certainly there's a lot of effort being put into studying these agents. And that's where I'll finish off. Hopefully I'll have time for questions if I get back off my flight that's scheduled for the same time as this meeting. And if not, I hope that was pretty clear to you all. Okay, thanks.